I'm John Glaser, as you might have gathered here. Before we get into the core of my talk or comments, I just wanted to point out one thing. I got here a little bit early, and in my daily quest for 10,000 steps, I was walking around the immediate neighborhood. About a block that way is a charter school, and the name of the charter school is the String Theory Charter School. And I thought, String Theory Charter School. I wonder what management decision process led to the selection of string theory as, not Ben Franklin, the 57,000 options here. And I was pondering that. I obviously deep thought here. And then I was thinking, well, when you go to the String Theory Charter School basketball games, what does the mascot look like? Let alone the fight song for the String Theory. So anyway, you may not remember anything that I say, but you'll be pondering for the rest of the day. I wonder what the String Theory mascot looks like as we go through this. I'm going to talk, this is the title here, and let me give you a little bit of a précis of the overview of this, and then we'll get into the core of this. About a couple of decades ago, a guy named Jim McKinney published a book called Waves of Change. And Jim was at the Harvard Business School at the time, and Jim's basic thesis was that at any moment in time, all organizations in a particular industry have a dominant design of the core IT systems that they use. And this design is influenced by the nature of competition, it's influenced by the core processes that they take on, it's influenced by regulation, and obviously it's influenced by the technology that is available at the time. And as you go across organizations in that industry, you see very similar designs, whether it's airline reservation systems or yield management systems at the time, or what banks use to debit and credit, et cetera, and lots of different vendors and some nuances, but fundamentally similar design. And every now and then there is a set of forces, and they can be regulatory forces, they can be environmental forces, they can be economic, they can be technology that changes the dominant design in a material way. And the basic point here is that we are in the early stages of a series of forces in the healthcare landscape today, certainly in the US, but I also have the advantage point of seeing it in other parts of the world, that will change the dominant design, or sort of the major way that we think about the systems that we put together. We'll talk about that, and that's sort of the basic idea. You can tune out for the rest of this thing because you've gotten the essence of what I'm about to say. The usual disclosures: I am paid by Siemens Healthcare, just so that you're aware of that. But obviously this will not be a commercial in any way, shape, or form. There are some learning objectives which are behind all of this, sort of sub-bullets under the main bullet. And so you'll look at those briefly, and then you'll scratch your head when we're done saying, I don't remember covering any of this material here. So but let me start with the core thing. And we're not going to spend a lot of time on this slide because this is known to all of you because of you serve and live in this particular industry. But the extraordinary anxiety and concern about the cost of healthcare. There's also concern about quality and access, but frankly it's dominated by the concern about cost at the end of the day. And a little bit of mitigation in the last couple of years, but the trend appears to be picking back up. This is not strictly a US phenomenon. Concerns in the Far East, concerns in Europe are the same kind of cost for all kinds of reasons that you understand and we won't dwell on. The consequence of that is, in particular, and this is particular to this country, is a shift in the reimbursement approach. So if you look at the far left, today most providers have a modest amount of their income based on how well they perform on quality or cost. DRG is an example, but most of it is still fee-for-service, paid for volume. You get over to the far right, and the payment they receive is dominated by various types of mechanisms to reward for high quality, reward for efficiency, reward for a variety of things, or punish it, frankly. And there's this real mix and series of species of payment mechanisms. There's bundles, there's episodes, there's shared savings programs, accountable care organizations, never event, readmission rates, this amazing series of species that are being added to the core. And fee-for-service doesn't go away, it's still 20, 30% at the end of the day, but it's becoming a much more complex environment. All in an effort to, quote, bend the cost curve, raise quality. Nobody knows where this will work. It's still very Darwinian and evolutionary in lots of ways, but clearly we're heading in this particular direction. I suspect all of you are familiar with Clay Christensen's disruptive innovation. Basic idea is the major disruptor in healthcare is the payment mechanism, fundamental. And that's what we are in the very early stages of, a very, very significant change. That in and of itself is profound and will be quite consequential. Related to that is shifts in business models. And so we're not going to go through each row here, but the shift from the sort of care provider on their own to the team. My eldest is doing her residency at vascular surgery at Penn right now. It's interesting to me at Dartmouth when she was in medical school, the emphasis on team in her training, which was unusual considering some of the ways we've educated over the years before. This notion of keeping people healthy, being responsible for outcomes and all this kind of other stuff here. And a lot of these slides are easy to put together. It's actually quite hard to do this if you're in the middle of care. I remember working with the physicians and the nurses at Partners Healthcare, and we could talk about your job is to keep people healthy. Yeah, but they didn't really know how to do that. We weren't organized for that. We didn't create time for that. There are big organizational models that have to be put into place to make all this stuff happen. So the nature of the work and the way it operates will change. It needs to move from the left to the right, and we should not underestimate how hard this is across those that deliver care. This is very challenging, very difficult, but nonetheless will need to occur if we respond to the changes. The second or third within reimbursement is that we'll begin to evolve from care for those when they present themselves as sick. That's it's sick care is what we fundamentally deliver in this country, to notions of sort of episodic sick care, is to managing people with chronic disease for all the quiet reasons that we know about. I'm expecting to live a long life. I just hope the decay is slow and gradual. Actually, there's a saying in the Glaser family, they live forever, they just don't know it. So I'm really looking forward to my closing stretch here. But nonetheless, a care model, as you know, that will emphasize chronic disease, and that is in a lot of ways new. Not for all organizations, but certainly for a lot of organizations that I know. The other part on the right is that the organizational models, this creation, the extraordinary consolidation that is going on in this industry, the creation of accountable care organizations. And you have to make a distinction between accountable care as a payment mechanism and the organizational model, that tries to bring together lots of providers, non-acute, acute, outpatient care, et cetera, into an organized system of care. And in addition, there's new participants. The retail pharmacies becoming more engaged in the management of primary care and the treatment of chronic disease. The life sciences guys, the pharmaceutical companies, saying, geez, we know a lot about diabetes, we make drugs for diabetics, maybe we should get into disease management. Health plans buying up and trying to get into a closer to disease management and the delivery of care, sometimes buying provider organizations. So we're seeing all these different organizational models, the integration across the continuum, new participants in new ways. It's interesting talking to members of CVS and wanting to have the pharmacist to be more of a team member in the provision of primary care and engage more actively in medication management with the caregivers. So those shifts in model are occurring. And then last but not least on the major shifts here is this notion that a lot of the processes that we have in care are very complex, you know that, and at times just don't work very well. So in addition to responding to reimbursement, to engaging in new business models, to forming new types of organizations and making sure that they work fairly well, it's tackling some of these very fundamental challenges, and these are quite hard. Remember, in the outpatient care one you see here is a Pew survey of patients years ago that said, to what degree do you think your doctors talk to each other daily about you and your care? And 85%, this is a daily occurrence. My doctor is acting as a team to think of me. Not a chance that is going on in any regular way or that they even know who each other is. So there's a lot of work that has to be done to take these core processes that are very complex, don't work very well, and make them better. So that's what we all are here for as part of the work that we do in different capacities, is to address these wide ranges of challenges. Now, it's not lost on me, and it's not lost on you, and frankly, it's not lost on anybody, that you can't address this stuff without a very sophisticated, solid base of information technology. Because you got to do all the things that are the bullets on the right here. That's not particularly insightful on my part, but it's clear that there is a big uptick in spending on this stuff, implementation of this stuff, all in the hope that we will leverage the technology wisely to improve the care, bend the cost curve, et cetera. And increasingly in the critical, and I think this is accentuates the importance of the work that Doug Fritzma and his colleagues do, is it is heterogeneous and always will be. So interoperability will be crucial to make sure that we can actually perform all of this over a base of systems. Sometimes in a metropolitan area like Philadelphia, if you look at how many different EHR vendors are there running today, it will be in the 70s to 100, the number that are running today, and that number is unlikely to change materially in the next couple of years. So that's it. Now, we're sort of zeroing in on this basic idea here, but we'll make one more stop before we do that. If you look at this and you spend, as I do, a fair amount of time with what they call the C-suite, you know, the CEOs, the chief medical officers, the CNOs, all that kind of stuff about, well, how do we respond? You know, we're a health system or a hospital or whatever, and we see all these changes. What do we need to do, or what types of technology investments do we see? You pretty much come up with this list. I mean, it's a fairly high-level list, but it's a pretty typical list. And obviously an electronic health record that spans some continuum, so it's easy to share the data, have workflows and rules engines that traverse various venues of care, the user experience is consistent. So that is a dominant EHR, and you know, you could cite Epic as being the organization probably established that model more so than any other, Meditech also in this industry. The other is the revenue cycle, and so that the ability to schedule across the board, share the demographics, the insurance information, and as we get into bundles where you submit one claim that reflects the aggregation of charges across outpatient, inpatient, and rehab, you need to group things across the revenue and submit one claim that is a charge grouper, so to speak. A lot of BI activity, obviously, to measure costs and quality and to do predictive this and predictive that. Along with the interoperability, the health information exchange, and obviously to broaden into hope, more of an API service orientation. Engaging patients in lots of ways that I still don't think we understand very well about how best to engage patients. And then last but not least is a series of services that say I spent a boatload of money on this stuff, it's agonizing to put it in, I got to get the yield. And so how do I make sure I design my processes, utilize it correctly, et cetera. Striking to me, and just to show you where the industry is, you can go into a number of C-suite conversations, talk about all this data they're going to need. They actually don't know how to collect it, they don't know how to use it, and they don't know how to act upon it. And we're still at very fundamental stages in very many ways, shape, and form regarding how to really use this stuff in a mature, sophisticated, clinical, and managerial way. So that's the list. Now that's important, I think, in a way, but this is where the sort of design notion comes in. One of the things I think we have to be aware of, and aware of it as a vendor and aware of people who deal with vendors or write your own, is that the basic design and ideas behind the EHR and the revenue cycle that dominated over the last decades will have to shift in the years ahead. And so the one way to phrase this is you got to be careful about not adopting your mother's EHR. And in all fairness to your mother and mine, who we all love dearly, I'm sure most of you do anyway, is that you got to be careful about that because the world is shifting in a way that may make that limiting. So here's a little summary of the Jim McKinney argument, and here are some examples. So if you look back at banking over the course of years, several decades ago, a bank could not engage in the development of a wide range of investment options for you. Mutual funds, it just couldn't. It was illegal to do that kind of stuff. And that has been deregulated in more recent times. And now, for example, if you bank at Bank of America, they have a Merrill Lynch option that allows you to move your money in mutual funds, this, that, or the other, to spread across the board. So there was a regulatory change that opened up fund management, something for them, and as a result, their systems changed. Now they're still recognizable. You still put deposits in, you take money out, you still got a debit and credit, they still have mortgages that they do, but the core of them changed rather dramatically. You can see the effect of the web or the technology. Retail's a different animal now than it was 15 years ago because of the ability not only to buy remotely, but to do comparison shopping, things that, to go into Best Buy and sort of look at barcodes and then go home and invest here too, or to do all the research before you go in. Similarly, content distribution. Actually, certain parts of the industry are being destroyed, fundamental, because the basic mode of a CD to get music out the door, print to get paper out the door, news out the door is being evolved. So you see in a couple of areas where the technology and or regulatory and or economic forces are changing the very nature of the systems, and one including the health insurance or the area that we're in here. Now the forces that will shape that, are shaping that, are reimbursement changes, organizational model changes, business model changes, along with grappling and making more effective these processes that traverse a variety of care settings. I suspect there will be three broad ramifications about how we put systems together as we understand all of this stuff. Now I also want you to sort of appreciate how evolutionary this will be. I think we will learn along the way how best to do this. And so it's not as if I or anybody else has got, this is the blueprint for what it will look like 10 years out. It will be quite iterative and evolve. And so I think we'll take the collective energies of us all to be smart and thoughtful about what we learn and what works and what doesn't, et cetera. But anyway, three fundamental forces. The first, which we'll talk about, is this movement from what I would refer to as the transaction-based EHR to an intelligence-based EHR. And let me give a little background. When I was at Partners Healthcare several years ago, and in my tenure there, put in 11 CPOEs and 4 revenue cycles and a bazillion outpatient EHR systems, I used to think, what are we fundamentally doing here? I mean, at a very fundamental level. And that is, we were putting systems that took paper transactions or manual transactions and automate them. Write a prescription, document care, retrieve a result. Lots of good stuff happens as a result of that. And in fairness, there was some decision support and logic that surrounded it. But the core thing was to essentially automate the transaction. And that was hard. In the outpatient setting, there's not enough time to do all this stuff. So it's hard to get it done so it's quick. It doesn't have to turn into this big time sink along the way. In the inpatient setting, the hard part was just coordinating everything, making sure that you still have time constraints, but not as severe. Is how do I make sure I know all of the activities and am efficient in all of the activities? It placed a premium when you design systems on being speed. The whole thing, reduce the number of clicks, make it easier, make it more intuitive and all of that kind of stuff, and make sure, for example, if you're in the outpatient setting, that the CHR supports ophthalmology and oncology and cardiology and OB and primary care, because there's amazing diversity of care settings and menu. Very difficult, challenging design questions. And they will remain important. It's not as if all of a sudden clicks go away in terms of being relevant. They will remain important in the years ahead. And obviously there was a, quote, ROI, or value justification that went with that you can see here. So while that remains important, what it still has not fundamentally done is address a number of core challenges which traverse here. One is the quality is still really uneven. Across the board. And so we have yet to show in any demonstrable, material, and comprehensive way. Lots of studies, I get it, a number were done at Partners about the impact of quality and efficiency, but nonetheless, if you go back over the series from the Elizabeth McGlynn Rand study to the current era, is how much we've actually changed due to IT, so we still have work to do on the quality side. The second is there's too much to know. It has been for quite some time if you're a caregiver, and it's just getting worse. Remember when my daughter graduated from medical school and, give her the big proud fatherly hug, and I said, just as words of wisdom, kid, this is the peak of your knowledge of medicine. It's all downhill from here on out. And that was just really pepped her up to go out and to conquer the world. And that's what I'm for here, and this kind of stuff. But it will be a challenge for her. It's a challenge for all of you who deliver care, and increasingly just to master the domain and to keep up on top of this stuff. The third, and this is a repeat of some of the stuff mentioned before, the processes are really screwed up. One of the striking observations in my time as a CIO is worked with some extraordinary caregivers, unbelievably gifted as human beings and caregivers, clinicians, physicians, nurses, etc. But the processes that surrounded them were just appalling in terms of how well they did not work. So you look at the second row here. 1,000 women with marginally abnormal mammograms, and a third of which had no appropriate follow-up care because paper fell through the cracks, physicians got tired, all kinds of stuff. And the consequence of that was often stage 3, stage 4 cervical cancer, things like that. So when we look at this sort of broad set of challenges, obviously there's a need to fix this. In addition to this slide here, is the data is amazingly awful and poor in some ways. So, it comes in, it's inconsistent. We had data where the patient was a type 1 and type 2 diabetic. Pretty cool. I didn't know that was possible to be both in these things here. Gaps in time. You guys see this as well as I do in lots of different ways here. Some ways I think the HIE is a mixed blessing. On the one hand, you see data that you didn't see before. On the other hand, you see data that's inconsistent and conflicting, across the board here. So the whole point of this thing is the movement, while preservation of the critical aspects of transactions, is the movement of intelligence into the EHR, broadly speaking, lots of different forms. One form is illustrated here, is having the machine reconcile differences in the data, saying, listen, there's 2 different facts here, or I don't see smoking on the smoking list. I'm going to go through the data using a variety of NLP and other techniques, suggest this is the truth, best I can tell. Present it to the caregiver for affirmation, etc., but to use the machine to reconcile. And a bunch of other things. And this is not new territory in lots of ways. It will just need increased emphasis and has to become much more central to the systems we have. The ability to help guide a clinical or therapeutic decision. And so what's the right way to treat a form of leukemia or whatever? To ensure that the sequence of activities, and the sequence of activities in a process could be those that are related to the evidence of diabetes or asthma or whatever. This is the right sequence that ought to occur. The sequence could be what I refer to as disease-invariant processes. Follow up an abnormal result, a transition of care. They happen all the time across a wide range of diseases. They just have to work well. And at times the processes, frankly, are reimbursement-centered. I want to get my 3% under value-based purchasing. What do I have to do, to make sure I get paid, not only deliver good care, but get paid well? So the use of workflow engines and other forms of rules engines, et cetera, to guide this. The ability to capture and report data, to have the machine extract the quality measures, reconcile discrepancies, and present them to avoid a lot of manual overhead that goes with that. And the other thing about intelligence is it's often human. It's actually people talking to people and sharing and supporting the interactions of a care team. And I think we're still learning about that. The example of what this interaction might look like is in a lot, and just to show you how the design of systems might have to change. Right now, in a lot of electronic health records, you have physician documentation and nursing documentation and documentation that the therapist does, et cetera. Each has their documentation that they do. In a team-based care, there is a document that is contributed to by all. They may have their sections that they do, including the patient. So the movement to documentation, which is the patient's documentation to which the team contributes. It's a different design orientation. Similarly, having my work list and your work list and your work list, that notion of individual work list, actually there's a collective work list, each of which has different tasks that we assign. So we will move to this form of intelligence. It's a lot of the logic engines that go through, but it's also looking at the data and cleaning it up, involving new ways of people being collaborators. So that's the first one. The second one is the accountable care processes. Now, the basic idea here is we talk a lot about we will be responsible for populations. And the core points here is who is it that defines the population? The answer is those who purchase care define the population. I'm going to tell you who I think, first of all, what it means to be a diabetic and who's in that. And so that's just be sort of where the definition comes from. The second thing is that the population we often treat as being the chronically ill or the people who've been immunized, sort of a public health orientation. Those are both correct, but the actual definition will become broader. A population includes people getting their hip replaced. So that, all those people from testing to surgery to rehab, et cetera, that is a population. It's got different temporal boundaries, different notions of care, but that is a population. Other populations, everybody discharged today because I got to manage them to make sure they're not readmitted in 30 days. Very much broader definition of population than we're used to. So if to take stuff from chronic disease and extend it across the care venues that occur. The other idea here is that for the basic idea, I said every member who is a member of a population. Remember, people can be in multiple populations simultaneously, not just multiple chronic disease, but getting your hip done at the same time, or smoking at the same time. Is for every member of that population, there's a care plan. What's the game plan for Mrs. Smith, given the population she is part of? You take a middle-aged guy like me and say, all right, he's needs to take a stat, needs to get his colon scoped every 5 years, and we just made sure he doesn't turn fat on us. And so there is a game plan for John, pretty modest plan, but it's different than a 22-year-old plan, and it's different from somebody who's 85 with lots of challenges going on here. So what's the plan? And not just the plan for the 5% who costs the 50%, but the plan for everybody. Everybody that I'm responsible for, I need to have that plan. So what I want to do is, given the plan, is using HIE and intelligence and all this other stuff, is there a material deviation from plan? That's what I want to know. If you're on plan, I don't care. I'm happy for you, but I'm not going to spend a lot of time on it today. Figuring out materiality is actually tricky to go off and to do. And materiality can be a blood pressure of 200 over 100. That's not part of the plan, is having that kind of blood pressure reading. Materiality can be seen up in the emergency room last night. That's not part of the plan either. That's not what we had intended. So it's a series of clinical data. It's a series of events that occur here. Now, having had a material deviation, I need to let somebody know, and this is what the machine can do. The machine can say, I don't necessarily need to give all this to a case manager. I'm going to send an email or an SMS text to the patient and say, you missed your appointment. That's not part of the plan. The plan is you go to your appointment. So I want to let you know, and by the way, click here and we'll reschedule you. Or it can be to someone in the practices, you need to renew the meds, because obviously the guys run out of refills. Or in the case of 200 over 100, it may be a nurse practitioner or a physician. So there's this plan, materiality deviation, set of logic which guides it to the right person and makes sure that we get closure on this thing. The notion of risk here is, what's the notion of risk mean? Risk is actually the likelihood or the probability they will be off plan. And so that's really what risk is all about. There are a series of factors that would cause us to be worried more than normal about whether this person is going to manage their diabetes or they're going to show up for the appointment. They may be poor, not have the money for their copay, and so they're a higher risk here. So we'll introduce population health as part of this thing. And it will involve this sort of understanding that at the end of the day, the way you get measured and paid is when you roll up the individual plans, the deviations from the plan is how well did I do in aggregate. So it's an aggregate way of looking at the performance along individual plans. And this has, and on an old CIO, you have to have screenshots. So here's the obligatory series of screenshots that we will go through. These are Siemens screenshots, but a lot of people have these kinds of screenshots. So this is kind of what it looks like, and you know these as well as I. This is sort of readmission. So how are we doing? Because we're looking at the aggregate of this population, people discharged from the hospital in the 30-day window after the fact, to see whether we're doing a good job or a bad job, and whether it's variation by types of providers, types of services, etc. This is you can't read this. But anyway, that's also a requirement. So you have one incomprehensible screen. This is it. It goes through here, and you can even stand 2 inches from it, and you couldn't read it. I can't read it. I don't even know what it says. I do know what it says. So what this is what we call concurrent clinical quality. So these are people in the hospital right now. Each row represents a patient. All of these patients are in the hospital because of a heart attack. That's fundamentally why they're here. Each of the columns represents a step in the plan. This is the plan, okay? So each column says this should happen, this should happen, this should happen. Sometimes in sequence, sometimes in documentation. These particular steps are linked to the value-based purchasing program that Medicare happens under the way here. So I, at a glance, of people in the house, that's my population right now, is people who have heart attacks in the hospital right now. And that's the population I'm worried about, is I want to know where are we on plan or off plan? And I can see at a glance, on plan, off plan. I want to know for care reasons, I want to know for reimbursement reasons, but this is a form of population management, different again from managing the asthmatic and the diabetic over time. But in both cases, the real-timeness of this matter is not particularly helpful if you find out 60, 90 days after the fact that you did a cruddy job in managing a series of population. Not only are they deteriorating or not advancing, but if you're a CFO, you say, I'm losing money while that is going on, and I've got margins which don't allow me to lose money to any appreciable degree. So one of the design changes will be this, is the movement from a prior generation, I think, not necessarily indicative of all of these, or all offerings, of population management tools to one that we only worry about the 5%. Fairly static risk categories, LDL above or below a certain number, or blood pressure above and below a certain number, et cetera. Often you had, here's my diabetes registry and my asthma registry, and they were quite silo-esque in lots of ways that we did this. We gave this list to per person of people who had missed their appointments or did this, and an amazing amount of manual work. One of the striking sort of examples of Darwinianism here is the number of patient-centered medical home experiences that are losing their shirt because it takes so many people to manage these lists. They get crushed under the labor costs of these things, and that obviously is not a setup for the types of improvements we'd like to see. We're going to move to this generation we manage everybody because somebody who's actually a middle-aged guy like me may be on the edge of being a high-risk patient if we're not careful. So we've got to manage everybody. And obviously you want to keep the 25-year-old lifelong habits that sort of mitigate the risk that they will ever incur some of the maladies that afflict people who are much older here. We want to make sure we can sort of manage risk according to conformance to the plan. We can put multiple sort of populations together into an integrated plan, both for the patient but also for the caregiver. And critically, I think there are ways, frankly. If you say that the ratio of case managers to patients being managed is 1 to about 250 to 300, it's roughly the ratio you see a lot of. You can get that up in order of magnitude, I'm convinced. You can get 1 to 2,500, 1 to 3,000 through a lot of process automation work. So we will shift and design across these two from the first to the last. And then the last. I'm going to roll here, so I'm going to start skipping all the verbs here just to make sure I cover everything that I want to cover in the course of the remaining time that I have here. One of the other things, as you saw in the prior dominant designs, is technology at times has a material consequence to the design of these sort of core systems, and this will be the case here too. I think in the course of the history of IT and the use by business, and I would include hospitals in that category too, there have been 5 revolutions. One is the mainframe, the second is the mini computer, the third is the network personal computer, the fourth was the web, and now we're in the early stages of the 5th revolution that we're going to go through, and that will shape what we do. Now, the basic notion of this is that the phenomenal, it's the sort of the Internet of Things. everybody in this room has got a mobile device on, a very potent machine connected to the network. And if you don't have a mobile device on, it's because you left it in your hotel room. It was not a game plan on your part here. And if you look at all the microprocessors that are out in the world today, what percent are in mobile devices, laptops, servers, all that kind of stuff? The answer is about 20%. Where are the other 80%? They're in your car, they're in elevators, they're in processes, they're in stoplights, all these kinds of things here, et cetera. All network. So here's an example, the Fitbit, the quantified self, where we now have people on mounted steps like me, or skin temperature, whatever it is you're deciding to measure for whatever reason you're deciding. Actually, I teach at Wharton, and one of my students was telling me about this watch he's got that measures his skin temperature and how excited he was about skin temperature measurement. And I thought, I love you, buddy. And I thought, on dates, you must be lethal, absolutely lethal. So let me show you my skin temperature. What the hell? Wait, where are we going with this? So anyway, it is, but you don't understand what I'm saying. It's a sort of quantified self. So if you take a look at the sequela of all this, there's this extraordinary, absolutely extraordinary. You look at the growth of mobile devices across the globe, particularly in emerging economies. Just unbelievable what is being done here, all networked, et cetera. And coupled with some amazing advances in very sophisticated sensors, sensors of body, sensors of temperature, traffic, a lot of smart cities that sense where traffic is and change stoplight frequency or sense where the power is going, and a lot of sophisticated ways of measuring things. Spewing out amazing amounts of data. Absolutely, you guys have heard the drill about how much has been produced in the last 2 years. A lot of it drivel, frankly, but how much has been produced relative to all information production over time. So this is the phenomenon that's coming out. It's the phenomenon that says I can use this in ways that we're still trying to understand to orchestrate complex processes, like moving traffic through a city, like moving electricity through a grid, perhaps like moving patients through the care system, through the hospital, et cetera. I can use this data to get real alive, real world information on what is really going on, the sort of the internet dust and debris about what is really going on with some very novel analytics, et cetera. So this will enable us to do a wide variety of things and to open up some doors that the challenges that are confronting us of reimbursement and business model change and organizational model change and care process, et cetera, hitherto have not been all that easy to do. The other is you take fundamental human activities. The notion of being a member of the community is a fundamental human activity. All of us are, unless you're a sociopath. So in the course of that, we take tools that enable communities to be different, to be globally spread, to where you actually physically don't need to see each other, et cetera, and all there's some very core fundamental activities and attributes of what it makes to be a human being. So you put all this together, and here's just some examples of this. Some work done by some colleagues I have who are up at Siemens Healthcare, and just beginning to see, this is the classic example, can you go into EHR data and begin to do post-market surveillance or comparative effectiveness? The answer is you can. And even if it's not definitive enough to lead to drug recall, it's certainly canary in the mine type stuff, which can allow you to get an early signal on possible trouble. So in this case, you can see the 4 medications being compared for relative risk of a cardiovascular event, and finding, at least in data from the Brigham and the Mass General and the community that surrounds them, there is. So very novel ways, and could be material improvements in the ability to engage in signal detection of care quality and adversity and things like that. Another thing, and this is some work that Siemens is doing, is can you develop algorithms that incorporate data from, you can see on the sort of second to the column, imaging data, mass spec data, pathology data, EHR data, and improve and get high sensitivity, high specificity algorithms to help make diagnostic and therapeutic decisions about the treatment of cancer. And the answer is you can. Taking these very diverse types of data and each improving the ROC curve by being additive. And a lot to learn about how to do this overall, but nonetheless taking novel forms of analytics, both signal detection, but also algorithm creation here. This is an example too, and I'll just go through this briefly, and then then I'm done, and we'll see whether there are any questions created here. I have been married to my wife for 39 years. Pretty cool. Now, about 5 years into the relationship, I was forbidden on any birthday or holiday event to buy clothes, perfume, or jewelry because I had shown a remarkably ineptitude at doing any of the three well. and this stuff. And if I did stumble, and I had to bring the receipt because it was immediately going back and being exchanged for something that was really more obvious. So anyway, you got me. And I suspect that I am similar to other folks in this audience, or some people in the audience will know people who are like that. So I have, nonetheless, birthdays happen. And I will sit on the couch trying to watch a Red Sox game, given the timing of the birthday, and I'm desperate to find something, because I got to get a gift. I'm forbidden to go these 3 categories, and I'm surfing the web, just hoping for inspiration. I'd be happy with the clouds part in the Noah type sense. I'd go, if worse for me, man. You just give me an idea here. So I wind up, and if you watch my movement through the web, it's this erratic pattern. So I'll go close to a jewelry site, then remember that that really is a mistake and back away. I'll go into the Home Depot site, get all excited about a chainsaw and realize that that'll probably go over poorly. I just want to go over well. Or the chipper. I was thinking about the chipper for a while. That'll probably go over poorly too. Then I'll wander in because I want to say, what's the deal with Kim Kardashian? I want to be a happening, conversive type of guy. Then I'll go and check the email, and I'll check another box score. And you just watch this path all over Kingdom Come. And obviously in this sort of new world, and obviously people at Google and others are looking at this kind of stuff, is watching this pattern saying, what the hell is going on here? This could be random. But what you'd like to do is early on to say, it is clearly a middle-aged guy in a long-standing relationship who is looking for a gift, but is radioactive in certain categories. Let's help him out. And by the way, he's got company, because Phil and Charlie and Kevin are similarly inept, and here's what they did. And the last, so why don't we serve up what other morons like him have done and get him out of this jam here. So the notion of it, it's a classic example of bringing together lots of ways here. It is in a sort of odd way. It is intelligence on top of a transaction. So intelligence trying to infer what the next transaction ought to be. It is grouping me into a cohort of like-minded people with similar types of challenges, and it's obviously leveraging the technology advances that go on here. So anyway, that is the conclusion of my comments. The point of this last slide, and this is imperfect, is the result of this is again, going back to the core idea, which borrowed liberally from others, is this notion of a dominant design, and the fact that the EHR in the years to come, you will see the EHR that we've seen over the decades leading up to this. You'll still write prescriptions, you'll still look at results, etc. But the design of it will have to shift in ways to incorporate and to support the wide variety of very fundamental changes that are washing across our shores, and probably to incorporate the sort of core ideas of being more centered on populations and plans for individuals, as distinct from a repository of data about an individual. What's the plan behind the data that goes with that, along with obviously capitalizing on a wide range of technologies. I think it'll be an exciting journey, it'll be a very interesting journey, and I frankly think for all of you and all of us in this industry and contribute, it is critical that we do it well. Because at the end of the day, you know what we're talking about, and that is our collective ability to help those who deliver care to be superb at what they do. So with that, I thank all of you, and I see if we have a moment or two for a question. Thanks.